You gotta love that music that's playing down. How's it going tonight there, Alicia?
Pretty good, pretty good. Yeah, there's a beautiful day in the neighborhood.
Isn't it getting like super warm, like
Mm-hmm.
really quick these days, these years?
Yep.
Something's going wrong in the world.
Yeah.
Anyway, welcome. And I see a whole bunch of people in our comments saying where they're from. We've got lots of people there. Alicia, do you want to highlight
My,
anybody?
yeah, Susie from Miami. We've got New York, Texas. I saw a lot of people from Texas, South Carolina. That's one of the things we really enjoy before we bring everybody on. Los Angeles, California, Nebraska, that is seeing you guys say where you're from. Uh, just a heads up, nobody's done it tonight, but they do it. Sometimes you do not have to put your certification number in here. That is not how we work. But it is enjoyable to see where you're from. We do appreciate that.
And they're so good about it. They started doing it
Yeah.
before we even started looking at the chat,
Yeah.
like 10 minutes before.
Maui. Tammy's from Maui. Woohoo.
Oh, nice.
Yeah.
Well, let's get started because you're all here because we want to expand our knowledge in certification coding, don't we?
That's
And
right.
Alicia is the woman of the hour who's going to be with us for the next hour. And I am looking forward to hearing about battling bugs and parasites. I had my own experience living in Brazil for a year with a new family and a little infant that it got a tapeworm, and that really just nobody knew how to deal with that. So I don't know what they were coding for back then. That was a couple of years ago, but a few years ago, more than that. That's where actually I got started with CCO back in Brazil, if you can believe it.
Yeah, I remember.
Okay, so I will start off, and Alicia, you just go on ahead and get going.
Well, real quick, we are focusing on ICD-11. As you guys probably know, joining us, we will be talking about the first chapter in the code set for ICD, and we're going to look at what ICD-11 has to offer. Make sure that you take time to go see our previous webinar that talked about STEM codes and extensions. We'll have a little review of that here in a moment. The code range in ICD-11 is 1A00 through 1H0Z for the first chapter. And we want to make a special point to say thank you to Find a Code for sponsoring us doing this. If we didn't have them sponsoring us, it'd be a lot more difficult to offer you the CEUs. And so thank you to them for sponsoring the ICD-11 series that we're bringing to you. Every month, we'll be talking about another chapter in ICD-11. So special shout out. If you don't know about Find a Code, they're real easy to find. It's just www.findacode.com. The CEU information, when you registered for this webinar, you probably got a pop-up and you were able to fill out the information, but wanted to give you a little heads up that to claim your free CEU, you need to join the CCO free forum. Again, it's free. And that'll give you the one free CEU. Easy to do, cco.pe/forum. Again, register now to get that CEU. We'll announce the information more about that throughout the webinar. The link to the live attendance for the CEU is going to be up for 1 hour after the presentation. So you can still register at cco.pe/forum for 1 hour. After that, you're going to have to go into the forum to be able to get that CEU and take a quiz. Okay. We'll again tell you more about that at the end. And this is the way it'll be for all of the ICD-11 series. That's different than the other webinars that we do. Let's do a quick review. And for those of you who were not at last month's session, you missed out. So we're going to give you some highlights. As I said before, we're walking through ICD-11 to give you a better understanding. The previous agenda, we talked about the code types. We talked about the mechanics of post-coordination codes, what they looked like. And we also kind of did some playing around with the application of post-coordination codes. We reviewed some of the practical considerations with ICD-11, and we looked at the challenges and what the future development of the code set will be. If you haven't, you can still go out and see the last session for ICD-11. Real quick, and please put your answers in the chat. We'd appreciate that. If you had any questions about last month's that you pondered and you didn't get a chance to ask, you can ask in the forum, because now you're in the forum for registering. But feel free to put them in the chat. We're also wanting to know, what have you been hearing about ICD-11? Real curious if your employers are already talking about it, or you've been hearing some conversations about ICD-11 at the water cooler maybe. And what have you learned about I-11 so far from other organizations or just other webinars maybe that you've been with? And as we go through each individual chapter of ICD-11, think about some of the future questions that you might have, and we'll try to make a point to address those as we go forward. We'll be proactive about that. All right, let's go ahead and do a real brief review on ICD-11, the code set itself, the definition, primary codes used to describe clinical conditions or entities, and they are found in ICD-11, the tabular list for STEM codes. That's what we're talking about. The structure usually is going to be about 4 characters, and they're going to start with a letter followed by 3 numbers. Not all of the codes will start with a letter, though. Some will be numerical. However, for the most part, they start with and they're going to provide the core diagnostic information for post-coordination. The extensions, remember, you cannot use an extension code alone. I'm sure that'll be a future test question for when we get ready to test for ICD-11. Provide additional information. They really just tell the rest of the story. They're much more expanded than what we were able to use in ICD-10. They give us severity scale value, anatomy and topography, and like substances, for example. We'll be able to say whether a person had nicotine abuse or cannabis abuse and stuff like that. That'll be all placed in extension codes. And you might remember we had said that extension codes always start with an X. So that's a quick little review of what we talked about last time, and we kind of broke that all out. What we're going to talk about tonight, though, is the first chapter, and ICD-11 mirrors ICD-10 in that it's the same chapters. There are extra chapters than what we have in ICD-10. We talked about those in the previous webinar. However, for the most part, it's the same thing. We're going to talk about like bacteria, viruses, and those things we see at the beginning of the code set in ICD-10. Same thing in 11. It literally is labeled out the same. And then you go into the different cancers is next, and so on and so forth. We need to get a better understanding, though, about bacteria and viruses. And I'm sure we will have a lot of fun tonight trying to pronounce some of the, well, I will, and you'll have fun kind of enjoying me stumble on some of these terms. I did do a review, went through and looked at them again before we started tonight, but I always mess them up. So if it sounds a little wonky, make sure you do your due diligence, and you can go online and get proper pronunciation if you think I might have tortured it. Hopefully I didn't, because I did try to practice. Let's talk about bacteria first. What is a bacteria? They are caused by mycobacteria. They're cellular organisms that can reproduce independently. Viruses require a host cell to replicate. Now, why do you think that's important to know the difference? One of the reasons it's important to know is that if we're trying to treat or kill a bacteria or a virus, we have to know what their setup is. And again, bacteria are cellular organisms. And if they can reproduce independently, then how are we going to stop them? We're going to try to turn off their reproduction system so that they're not able to reproduce, right? You don't do that with a virus, because viruses don't reproduce that way. They replicate off of host cell. So we have to be able to turn off or take away the host cell in some form. This was a picture of the COVID virus. Most viruses all kind of look the same, though. Acute viral hepatitis. We're going to just jump right in and talk about some prevalent codes and diagnoses that you're going to see. And then we're going to talk about some unique ones as well. And not only am I going to show you the code set, but I'm going to also give you a little background, maybe to increase your knowledge base on these as we go forward. And we're going to do that with all of the chapters, because it's one thing to know how the code looks and translates and so on and so forth, crosswalks, but it's another that you educate yourself along the way at what the disease is and the disease process. So we're going to feed you a little of that as well. And it's kind of exciting, learning these new things. Hepatitis itself. Now, most of us probably are familiar with hepatitis. There's more than one type of hepatitis, though. And viral hepatitis, again, virus. So we know that it needs a host to continue, is a group of liver infections, and they're caused by 5 distinct viruses, and you'll see those listed out. Now, you've noticed here that the ICD-10 code is B17.9, but the I-11 code is 1E50 for acute viral hepatitis. Now, it doesn't tell you which one of the 5 that it is, so that would be unspecified. But the STEM code for acute viral hepatitis is 1E50. And there is hepatitis A, B, C, D, and E. And then with each type, they have a different mode of transportation and varying degrees of severity. So some people can have hepatitis and be asymptomatic for a very, very long time. And other people get very, very ill. Again, remember, viruses have to have a host. Acute and chronic viral hepatitis. Now, if we look at the codes, very easy to be able to distinguish, right? We have 1E50 for acute, and we have 1E51 for chronic. Very simple. And then I didn't go through and get the code for every single one of them, the different types, but B is going to be 1E50.1, and C is 1E50.2. Extremely easy. I know that I-11 sounds intimidating. And when you start to first look at it and you see how long those codes get to be, it can, it can be a little daunting. But now when you look at how easy this really is, the STEM code, as we broaden it out, it really works a lot like the other code sets have. Once you know the basics, it moves forward easily. So again, acute is going to be a 5-0, chronic 5-1, and then each one of the different types is going to be 0.1, 2, 3, etc., etc. HIV. Now, before we talk about this, I know you're probably thinking, well, is the guidelines for coding for HIV going to be the same as it is with I-10? And it's very, very specific. Remember, there's guidelines regarding not only sequencing, but differentiating and make sure you understand whether the person's HIV positive, which is asymptomatic, or they have AIDS, which is symptomatic. And the way they do it in I-11, that's really what they focus on. Now, we know with 10, we think HIV positive and AIDS, two separate diagnoses, very, very different. With 11, what they do is they separate them between symptomatic and asymptomatic. So your HIV positive would be asymptomatic, without symptoms. That's what the A stands for. Symptomatic would be AIDS, you have symptoms. With B20, that's AIDS, and that's the human immunodeficiency virus, or HIV virus. That translates 1C60. And notice that the reason it's symptomatic is because here it states with tuberculosis. Now, remember, I-11 is a global code set. So some of the ways that we've done it with I-10 is a little different than what we do with I-11. Some of the terms and verbiage is a little bit different, and that's because what we don't see necessarily prevalent here, we may be more so in a different region of the world. So what they're saying is that you have a choice between tuberculosis and the other one's malaria. So it'll say associated with tuberculosis or associated with malaria, and then there's other types. Now, tuberculosis, we don't see that very often here in the United States, although there is a significant uptick in tuberculosis compared to what they had gotten really lax on testing for tuberculosis, or required testing. Like beauticians used to have to be tested to practice or work, and then they dropped that about 10 years ago, I think, and they didn't have to be tested anymore. So that means that if you're asymptomatic and you have tuberculosis, you could definitely spread it to a lot of people. Now, HIV disease, it is a virus, but it has its own distinct code range stepped out. So it's a very unique diagnosis, and therefore it has it's a little bit separate when you go listing all the others. And it is separated from other sexually transmitted diseases. For the most part, we've always thought of it as a sexually transmitted disease, but they're saying not only is it that, but it also is, it can be transmitted in other ways, and it's over here on its own. I gave another example where we have 1C62 0.3Z. That's HIV disease, clinical stage 4, without mention of tuberculosis or malaria, unspecified. Just to kind of give you an idea, that is a STEM code, but how specific it gets when you start looking at the definition. Now, the advantage of that is we didn't have that with 10, excuse me. With 11, we can get really specific. We didn't talk about tuberculosis and malaria with 10. The with most of these codes, also there will be a code for obstetric. And with that, you'll notice that that particular code, clinical stage 4, and when you're dealing with pregnancy, that is a J code, JB63, and then the other stem is the HIV code. So that's 2 stem codes put together. The patient is pregnant and has HIV, and then you identify again that the patient's HIV, right? And so again, I wanted to give you a little example of what that looked like. With HIV also, we have QC90.6. This is being HIV positive. And notice the exclusion is the 1C62.0. So the QC90.6 is being HIV positive, not AIDS. So it's or you've got symptomatic and asymptomatic. Then I wanted to kind of give you a breakdown of what it looks like when you start looking in the index to divide these codes up. So first you'd look up human immunodeficiency virus disease, and it gives you the 3, the 1C60, 61, 62, and that is the HIV disease associated with tuberculosis, malaria, or without mention of tuberculosis and malaria. So that'll just be part of the verbiage with HIV and AIDS going forward with I-11. And then they have stages 1, 2, 3, and 4. And then notice you're seeing a very common opportunistic diagnosis, Kaposi sarcoma, that if the patient actually has Kaposi sarcoma, that's AIDS, right? Turns HIV into AIDS. And the code for that is 1C62.3 because it's stage 4. And then what does the patient have? They have the opportunistic virus is Kaposi sarcoma, which would be the 0. Now, there are some other codes that are in there that the ones that are grayed out are a different area. And again, in pregnancy. So I just thought that would be beneficial for you to kind of see how it's done in the index. We're not going to jump into the index anymore with this webinar, but we will in the future when we get in and practice some of them. Another area that is common is pox virus infection. And you say, well, how can it be a virus and infection? Well, it can, but they're saying the pox virus is, and you're not saying an infection like a bacteria. The diseases caused by pox virus, we have smallpox, cowpox, mpox or monkeypox, which again was in the news here, I think last year. And let's see if I can say this right, Molscum contagiosum. And if you're not familiar with what they are, smallpox, for the most part, is eradicated in the United States, and it really had high mortality rates back before we had the vaccinations for smallpox. But in 1980, it was eradicated. I don't think that globally they still have smallpox in other countries. Now, cowpox is a little bit different. I don't know much about cowpox. Monkeypox is again, with all of these poxes, they develop fever and a rash, and that's what people get so sick with is that high fever. But there has been a lot of outbreaks of mpox in the future, now, and so we're probably going to see that more in the future. The codes for these are 1E7 codes. So smallpox is a 0, mpox is a 1, cowpox is a 2. Pretty easy to follow. With infectious agents, there's also prions. You got prions, viruses, and bacteria. So I thought I might just give you a little clue as to what prions are, because we don't talk about those as much. The way they're transmitted is through infected tissue. Now, if it's ingested, then it ends up going through this one that is, I don't know that I think it's called Crutchfeld-Jakob disease, and it affects the neurological system and gets into the brain, and it's from infected beef. When I was reading this and doing the research, which I didn't make the actual link, but it made me think about those conditions that cows get where they have to end up culling the whole herd because of this infection. And remember their mad cow disease. I don't know how that gets in there. I think that was a big thing in the 2000s, but this is not that, as far as I know. The medical procedures, if you get contaminated surgical instruments or organ transplants, then you could get these prions. Genetic inheritance, some people do inherit this, and there is a unique aspect to prions, is they do not introduce an immune response and are highly resistant to heat, radiation, and chemical disinfection, making them difficult to inactivate. And that's why you see them getting on surgical instruments and stuff, because we do, you disinfect them, and we do that usually through heat and chemicals. Now let's look at some extension codes that will be prevalent when we're dealing with our bugs and viruses and bacterias and prions. One very incredibly common one is E. coli. That if, especially if you get, say, pneumonia or UTIs, that's the one I think of as with E. coli. And then again, don't forget laterality can also be involved. And this doesn't matter what chapter you're in, left and right will always be the same extension code. These are going to be extension codes that we'll have memorized, the XK8G for left and XK9K for right. But E. coli will always be XN6P4. However, since E. coli is so common with some diagnoses, they actually built it into the description. And when that's the case, the rule most likely will be you don't have to put the extension code. So I wanted to give you a couple examples. The first one is that we could be using two STEM codes. With pregnancy, you're going to have two STEM codes. You're going to have the pregnancy code that says the mama has this, and then again another code to describe what she actually has. So it'll be a little redundant. So if she has a urinary tract infection following delivery, then that's JB40.3. But if she has a UTI, site unspecified, because they'll say bladder, kidney would be your specificity, due to E. coli, then that would be GC08.0. So it's built into the description. We don't have to put the E. coli extension code on there. Another one would be pneumonia due to E. coli. And that is very common as well. Once they do find out what the organism is, it is, if it's E. coli, you don't have to put the extension code for CA40.01 because it's built in to the code itself. Now, could there be a rule that they change later? Maybe there might be exceptions to that. But if we follow the guidelines for I-10 that it will most likely extend into I-11, you're not going to have to add redundant extension codes when the description of the code is built in. That would be like in I-10, if the patient had diabetic neuropathy, you use the diabetic code with neuropathy. You don't have to code neuropathy in addition. Okay. Now that doesn't mean you won't have extensions like a diabetic with CKD, then it would be thinking like, okay, the extension code would be what stage, right? You'd have 2 codes that you would have to deal with. So it's a little bit different. Just heads up, be aware of that. Now, what would it look like if we're actually going to use the extension code? Acute vascular disorder of the intestine, unspecified, and the organism is found to be E. coli, then that would be the DD30 point Z. Z's are predominantly unspecifieds, and Y's are usually others in ICD-11. So we have an intestinal disorder, and a lot of intestinal disorders are due to E. coli. And so then you see that extension being used with the ampersand. So versus you notice with the 2 stem codes where we use the /. Now, if you were in the previous webinar, you'll remember we talked about that and how post coordination is used. But I looked at this a little further when I was looking at the codes itself, and then I realized you can have even more specificity and use an additional extension code to state where it actually is located in the intestine. So we can, if we have it in the duodenum or duodenum, that would be XA9780. And they had jejunum and I think one other place that they could identify that this vascular disorder was located due to E. coli, what part of the intestine. Pretty brilliant. And they had small intestine and large intestine divided up. So again, pretty exciting to be able to say all of that in that one code. And don't think that that is intimidating, because we just spelled it out. Herpes simplex infection, again, another one of those extremely common ones that we see. What are the different types? For herpes simplex infection, we're going to use 1F00. But for disseminated cutaneous herpes complicating other skin diseases, it'd be 0.03. For meningitis, 0.20, and 0.1 for infection of the eye, unspecified. So these are just ones that we pulled out. There are more, but we wanted to kind of give you a brief overview of what to look at. But I wanted to also differentiate for you the different types of herpes simplex, because it gets very confusing. So oral herpes, the HSV1, that is where you get fever blisters on the mouth, and some people are predisposed to this. And it can be because of things like stress, sunlight exposure, or even when you get really sick and you run a high fever, then you could have one of those pop out in your mouth. Some people never get them, and some people get them a lot. So it doesn't mean anything except for that they're just predisposed to getting them. Now, genital herpes is the HSV1, but it also is HSV2. This is specifically around the genitals, and that is different in that it has the itching, burning, and discomfort. There is the reactivation of the 2 is a lot more than the 1. And then we have herpes viral encephalitis and meningitis, and it's a brain infection or meningitis. It's spread through the bloodstream or direct pathways, and it can it doesn't really reactivate itself, but the other 2 do. But again, meningitis is a serious condition, and a lot of people succumb to that. If they get that, they'll do spinal taps to see if you've got clear spinal fluid. Interesting, zoonotic viral diseases. We don't even think about this often as that being what it's called. Doing the research for this was a little bit fun. So 1E31 is identified as zoonotic or pandemic influenza virus. And it means that it comes from an animal. And these can be significant public health concerns. It can spread globally, as we've already seen. An example of a zoonotic influenza is H5N1 or H7N9. Do you guys remember H1N1 and H5N1? Those are ones, those are different types of avian flus that went around, that people were infected by birds. And the pandemic ones that were caused by animals is the Spanish flu of 1918, the Asian flu of 1957, the Hong Kong flu in 1968, and in 2009, the swine flu. And these reached out globally. Uh, I remember one of my daughters actually got the swine flu. I don't know how the rest of us didn't get it. I thought it was very, very contagious, but she was incredibly sick. And they tested her and it came back as the swine flu. And it was about that time, 2009. Challenges with non-specific diagnosis codes. The thing we have to know about these is to pay attention to when we need to use extension codes to explain the rest of the story. As we're crosswalking, we've seen some really unique things. A850 is an enteroviral encephalitis, but it doesn't translate like that. When we have to translate it, we have to understand the verbiage and the type of disease to be able to flip and look at the actual meaning. So enteroviral encephalitis, how are we going to look that up? Do we look up encephalitis? Do we look up viral, to understand it? Well, what it translates as viral encephalitis not otherwise classified. But to be able to figure that out, we had to understand what viral encephalitis was, and enteroviral isn't in the description for I-11. So how did we figure that out? Or what was the aha moment when it doesn't immediately crosswalk word for word? Well, we have to know what an enterovirus is. And it is usually passed around through communities. It's contagious, and it's usually people get that when they have poor hygiene practices. So viral encephalitis is caused by various viruses, including enterovirus, but not all cases are viral encephalitis being due to enterovirus. So again, it gets a little unique. So how do you explain that? Well, you use viral encephalitis, and then you use an extension code to say what it was, right? So this is a perfect example of why that's necessary. Another non-specific diagnosis code, C14.2, is malignant neoplasm of Waldeyer's ring. Now, Waldeyer's ring is a little circle of lymph nodes in the back of the throat, and I found this diagram that thought this is really, really cool to explain the different lymph nodes. It's unique, and it is a cancer. So how do we translate that? Well, we have to say it's a malignant neoplasm of other or ill-defined sites in the lip, oral cavity, or pharynx, unspecified, and then we add Waldeyer ring. So what is real simple as far as description and verbiage in 10 is much more descriptive in ICD-11. So for that malignant neoplasm for all the different areas, that's 12B6E.Z, and then the extension code for Waldeyer ring is X, because extension codes start with an X, A8US7. So that's pretty long and intimidating looking, but it makes sense, right? Where we're just literally grabbing the two and putting them together with an extension, which is the ampersand. It's not two stem codes. Some coding clinic labs. We wanted to start giving you some practice areas where you can go do some research yourself. Now, I've got several listed, and the CCO team, thank you to them for going out and putting some of these together. But as we've been crosswalking this, it's been pretty exciting and fun. And it definitely gives you a boost in your knowledge to do the research. So I thought it would be a good idea if we had some examples of things we want you to go look at in the future. And of course, in your being in the club, you'll get access to this slide deck and you can have it in front of you. But I'd really be curious if you guys can come up with non-pneumatic Legionnaire's disease or Pontiac fever, gonococcal infection of the lower genitourinary tract with periurethral and accessory gland abscess. How about an epidemic loose-borne typhus fever due to Rickettsia prowazekii, and acute paralytic poliomyelitis wild virus indigenous. So that's some practice that you're going to get to do, and let us know both in the chat and in the forum when you come up with these codes. Code them in I-10 and code them in I-11. But while you're doing those little assigned homework or fun labs, we've got some other ones that we got for you. So A400 or A40.0, sepsis due to streptococcus group A, because streptococcus has lots of different types. How are we going to code that? Well, we're going to be using an extension code, but we're also going to be using two stem codes. So first, we've got bacterial infection of unspecified site, right? Because it doesn't tell us where it's located. And then what is the organism? It's Streptococcus group A, and then the patient has sepsis without septic shock. So that's going to be 1C41 for bacterial infection unspecified site, and then the extension code to say what the organism is, XN6LP. That means Streptococcus group A, no matter where you're using it, will always be XN6LP. And then what is the other stem code? What is the other diagnosis the patient has? Sepsis without septic shock. So again, that translates very specifically. And you think, well, you got to say the same thing, A40.0 and 10. It's definitely more problematic, or looks much more complicated to do it in 1I11. But remember, I always work this in, and you get tired of hearing it, I'm sure. But we code for statistical purposes. It happens to be a convenient way to get paid. We cannot break up and get specificity with A40.0. With I11, look how they can pull those codes and do some really in-depth analytics by having the code, the definition kind of chopped up and being able to place them in different spots. So don't think that that's intimidating, because A40.0 is replaced with this long diagnosis code. It's actually much more simple because we're piecing and parting it together. Moving on, what about sepsis due to Streptococcus A? Okay, we showed you that one, right? That was on the previous slide. But what if it's sepsis due to methicillin susceptible Staphylococcus aureus? Now we have A41.01 in I10, but in I11, we still have the original bacterial infection, which is 1C41, so that stayed the same, but we now have a different organism. It's not Streptococcus group A, it's now Staphylococcus aureus, XN6BM, and then we have sepsis without septic shock. So we can do an analytic where we pull all of the sepsis without shock, And then we can do another analytical rundown. How many of them had strep group A and how many of them had Staphylococcus aureus? What medications worked best for each one of those, and what treatment plans and protocols and stuff. So it is really, really exciting that we can maneuver and do some unique analytics. And then remember, on top of that, we're going to be able to use AI to give us more specificity and find trends that we wouldn't be able to probably do on our own. That's very, very exciting. What about meningitis due to Lyme's disease? A69.21, but in I11, we have two STEM codes. First, we have to state that the patient had Lyme's disease, disseminated Lyme borreliosis, unspecified. And then what did they have? Well, they had bacterial meningitis because Lyme disease is a bacterial meningitis. Isn't that exciting? Now, someone had asked, how do we know which of the STEM codes go first? There is a nuance to that, and we've been trying to perfect it as we crosswalk these. We've come to a decision, but I'll share that more with you in a future presentation, because I'd like to be able to give you some more in-depth examples where once we've got the basics down in some of these chapters, then we're going to do some more complex coding scenarios. And otherwise, it's a little hard to explain the thought process. Part of it comes from the CDC, how they define, and some of it comes from the World Health Organization, how they sequence things. And remember, we have to sequence kind of in a global understanding versus ICD-10 where there are guidelines. So some of that may change. So I'll share that with you more in the future. Don't forget to ask that again. All right, so we've looked at Lyme disease and causing bacterial meningitis. What about something that has to do with site location? Sepsis due to Enterococcus. That is A41.81. So first, what does the person have? They have a bacterial infection of unspecified site, 1C41. And then they have the extension code for XN1F7 for Enterococcus, and then sepsis without septic shock, which is our 1G40 code. We've been using that again and again and again. And see how we can blow these up and use different ones together. How about one STEM code and two STEM codes? So what if we have what is not necessarily common with glaucoma, but and I might not be able to pronounce this very well. Let's see, that is not pronounced chi. I think that's pronounced C. So it's onsoresius with glaucoma. We would have 1F6A.0, which is that condition of the eye, which I won't try to pronounce again. But then we have another STEM because the patient has glaucoma, and we need to know what type of glaucoma it is. So this one, they pick secondary open angle due to a parasitic eye disease. Okay, now the B7 3.02 didn't state that, but the reason we're using this as an example is that there is a whole bunch of different types of glaucoma. If you've ever had to do glaucoma or coding for optical, it's just crazy, the different types. So this is the one we picked. So it would be secondary, and it's open angle glaucoma, and then it's due to a parasitic eye disease, which is the 9C61.26, right? Very specific. And then unilateral unspecified. It didn't tell us which eye. So then we have to say K or XK70. So again, we have right, left, and if it's unilateral unspecified, whether it's right or left, it's XK70. And then we also have bilateral, which I don't remember that off the top of my head, but you will be able to remember it in the future because these will always be the same. Interesting, right? Well, what about, again, one stem code and two stem codes together? So we have measles complicated by meningitis. If the patient has that due to meningitis, that would be B05.1. Now, with ICD-11, it's going to be 1F03.2, measles complicated by meningitis. And you think, okay, that's pretty simple. But what if we have measles complicated by pneumonia? Now we have two stem codes. We have one, I think that's not supposed to say 1, I think that's supposed to say just 1F03.Y. And then / to show that we have another stem code. CA40.1Z says that it is viral pneumonia unspecified. So again, pretty exciting. I know, right? And using two stem codes with a / thyroid toxicosis with diffuse goiter with thyroid toxic crisis or storm. This will put you in the hospital code, but E05.01, and we're going to actually have two stem codes here versus you would think that thyroid crisis might be an extension code, but it's not. So 5A02.0 is the thyroid toxicosis with diffuse goiter, and then the patient also has thyroid crisis, and within I-11 they split that up. So thyroid crisis is in itself a stem code, not an extension code. There's different reasons why you could have thyroid crisis, in other words. We have E, the ones we just looked at. However, what if you have thyroid toxicosis with single thyroid nodule with thyrotoxic crisis or storm? Well, that case, we have 5A02.1, and then we have another stem code, which is the thyroid crisis, the 5A02.5. So isn't that interesting to see how that works out? Whooping cough, A37.00, due to Bordetella pertussis without pneumonia. And pretty easy, 1C12.0. It's all spelled out. It's a clinical concept, right? When we look, it translates almost 1-to-1. There isn't without pneumonia. That's okay. Now with pneumonia, then they would use that extension code. So then if we have whooping cough with pneumonia, oh, I'm sorry, it isn't an extension code. It's actually a stem code. I misspoke. I was thinking it would be an extension code. It was wrong. So we have our 1C12.0, and that's the whooping cough, and then it tells us with the pertussis. But if it's pneumonia due to other specified bacteria, it's CA40.0Y. Y's are others, Z's are unspecified in I-11. See how you're just getting smarter already? All these things that you're learning. We learned so much from the last presentation where we understood the stem codes and the extension codes, and we looked at a lot of extension codes and divided them up and said, hey, look, they're always going to be the same. Laterally being one of them. Tonight you learn the extension code of E. coli, and you're also learning the difference between stem codes and extension codes, where I thought that pneumonia would be an extension when in actuality they're using it as another stem code. Pretty exciting. All right, now typhoid meningitis, A01.01 in I-10, but in I-11 it is much broader, because we're going to, one, say that the person has meningitis via typhoid. So first we're saying other specified typhoid fever, the 1A07.Y, because Y is other, and then bacterial meningitis unspecified 1D01.0Z, because Z's are unspecified. Oh, you guys are getting it. All right. Now, what about typhoid pneumonia? Well, typhoid is bacterial. So we know that we have 1A07.Y, other specified typhoid fever. That's what the patient has. What is the condition because of that? They have bacterial pneumonia, CA40.0. So we put the two stems together. Tuberculosis of the lung, A1 5.0 in I10. I11, we have respiratory tuberculosis confirmed. Now, that is another thing that you'll see in I11. Some of this verbiage that we didn't see in I10. So 1B10.0, respiratory tuberculosis confirmed. What about meningeal tuberculocoma? That is 1B11.2. Unique, and yet right there in the same area. What about dengue fever or classical dengue? That's 1D2Z, just dengue fever. And then if it's hemorrhagic, that's going to be 1D20. Notice unspecified Z, and this time it is specified, but it's without warning signs. I thought that was kind of cool, right? B50.0, plasmodium, faciliparium, malaria with cerebral complications, because malaria goes into it complicates the brain. That's why people have hallucinations and stuff like that. It is almost it's a one-for-one translation almost in the description. 1F40.0. B67.0, Encinococcus granuloso, infection of the liver. And here we see that one-for-one translate, but we can have it of the liver, the lung, and the bone. And we're getting ready to wrap up, guys. We have A82.0, and that is Slavic rabies. That is going to be 1C82. And notice here, this is another interesting thing. You can have Slavic, urban, and rabies unspecified, and we specify it all out in I10, but in I11, it is all the same code, 1C82. And that's, remember in ICD-9, when hypertension had all the different ones, and then in ICD-10, it was I10. And now they kind of did the same, where it's like, we've got all this different specificity, and yet for I11, rabies is rabies. So I thought that was kind of cool. Interesting concept. Typhus fever due to rickettsia, I guess. And then we can have spotted fever and a pox, all divided up into 1C30, 1, and 3, and that should be a 0.2. Conclusion. All right, let's wrap it up, guys. Next topic. Chapter 1 was bugs, parasitic, and infectious diseases. So next will be cancers, and we've got a cute name for that. We'll let you know. And what did you think about doing these labs at the end? Give us a shout out in the chat, and let us know also in the forum that you're now part of because you registered. Is this a good format? Is this going to be a good educational tool for you to understand the the code set and the comparison of 10 and 11, and then also to really fill out 11 and feel like you're comfortable that you could actually start using it. And then we'll later, as we get more and more under more and more of an understanding, we'll start doing more scenarios, more complex scenarios, and we'll have the Q&A in the forum. Don't forget, guys, we have our QPin course. That is the latest course that CCO offers. It allows practices to use the G0023 code that came out, and it's not only beneficial to the clinician that and the physician that is using this and helping the patients, but it helps your patient population too. This patient illness navigator. Other CCO news, don't forget, we also have a monthly webinar, and the new one I think is Mania Madness coming up. March Madness. We did March Madness. That's what it is. So we'll shout that out here soon, and we're going to do a whole bunch of cases, not in 11. We'll be doing those in 10. And you can always view us on YouTube and Facebook, remember, just as always. And don't forget to submit your requests and topics to us. But Boyd, anything wrapping up the shout outs that we need to let them know about, you think? Can't hear you, Boyd. Your little mute thing's on.
That's right. Thank you. I would make sure that I wasn't burping or something like that during your talk. There's always people are coming in late and stuff like that. So they weren't sure if you were talking about ICD-11 yet. When is it coming out? I know you went over that earlier,
Right.
but let's just recap it for everybody.
That's a good point. Thanks for bringing that up. So in our previous webinar, we did talk about that a little more extensively. We do not have a date. It literally is an act of Congress to switch, and they had stated that it would not come any sooner than, I think, 23 or 24, because we've been talking about, CCO has been talking about it since 23, and we're actively working on projects, crosswalking and stuff, and we have no further information about that. I knew, and I've said in other lectures, that we knew it would not happen until after the election, and now that that's happened, I think that probably mid-year we'll start hearing more about it as things calm down. Another topic that comes off of that is people were concerned that if we pull away, if the United States pulls away from the World Health Organization, will that affect the change in the code set? And it will not. They may talk about it and hype it all up, but the fact is there is no copyright on the ICD code sets, and the World Health Organization more or less sponsors it and puts it together, but there's like 4 other entities, which we talked about in the previous webinar, who play an intricate role in maintaining and putting new codes in. So it is not about all about the World Health Organization. They just keep it organized. So don't worry about that, and don't play into that fear factor that I'm sure that they will use. But there'll be a lot of pushback, but it will happen because it allows us to capture statistics better, and it will allow us to integrate AI into the medical, and that the medical field even more than we're doing now, and that's a big push. So I think that will outweigh the other reasons why people postpone going from 9 to 10. I think it'll be a more smoother transition. That was a good question, guys.
And once again, you did an excellent webinar tonight. Thank you, Alicia, from everybody. And I always wanted to see if we could figure out some way to show people, because I know we've got a lot of regulars with us, but unfortunately we can't do that. So we kind of have to imagine that you're with us in the virtual audience, but you know that Alicia does a great job entertaining us all. So thank you, Alicia.
Remember that when you get in that the forum, and especially if you join the CCO club, that not the free form, but the actual CCO club. Then you get transcripts, because I know that was asked. You'll get the slide deck, the transcripts, the recording, and a whole bunch of CEUs that we have in the club. So think about that. That's cco.us/club. And yeah, I think it's Deanne wanted to know if a transcript. It's only available through that. And remember, 1 hour. You have 1 hour to register, and then you can get the CEU. And then after that, you'll need to take the quiz to be able to get the free CEU. But it
And
is
we should
free.
note that our transcripts are still being done by a human. So we haven't gone and sent it all off to automatic transcription by a computer or AI or anything else like that.
Correct.
So it's still being done. And we
They
thank
go in and take out on my ums and so's and funny little grunts and noises. And
you're pretty good at that, actually. or you ignore them, put it that way, and then you just keep going. So that's the important thing. Okay, great. So any other last words before we wrap up?
I can't think of anything, but we will, especially if you're in the forum, you'll be able, we'll blast out there. They get priority. You'll know what the next webinar is, the names and everything, but we will be talking about the very next section, chapter 2. And we have a real cute name for it. So
can't
we'll
wait to
announce
hear
that.
about it. Can't wait to hear. Okay, so thank you everybody for being with us, and we'll see you on the next webinar. Thank you so much.
Yeah, 1 hour. 1 hour, guys. So hurry up.
Later.
Bye.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.